Welcome and good morning. We'd like to introduce Dr. Daniel Bose, who's a medical oncologist at the University of Colorado in Denver. He's the associate professor and director of cancer research at the Denver VA Medical Center. He has a particular interest in HPV and HNSCC, salivary gland cancers, and aggressive thyroid cancers. So welcome, Dr. Bose.
Thank you. I think also we have Dr. Ryder, who is joining us from I'm guessing her home in Minnesota. So thanks for having me come to chat with you guys. I've done this a couple of times when it's been in Denver, and it's always a real treat. The ThyCa organization is a great organization, and the patients are always so well informed. I feel like we healthcare providers always come away learning a lot more than I feel like we end up teaching you guys. So we are going to talk about radioactive iodine refractory thyroid cancer and some kind of new advances over the last several years, and then maybe give you guys some ideas about future directions. I will say, as we are chatting, both myself and I think I'll speak for Dr. Ryder, you guys always have great questions. Similar, I'm sure there will be great questions coming in from the chat. Feel free to just raise your hand, ask away. This is, it seems formal because I'm at a podium, but it's really not that formal. Just go ahead and ask as we're going along. So some kind of general overviews. So we'll talk about some thyroid cancer just overall. I'm going to give you some definitions for radioactive iodine refractory thyroid cancer. We'll talk a little bit about the kinase inhibitors and targeted therapies that have come around in the last couple of years and are really, I would say, the standard of care at this point. And then we'll talk about some future directions, particularly Dr. Ryder will talk about redifferentiation therapy and then some new immunotherapy ideas that are coming down the pipeline. So just to remind everyone, the ThyCa conference is great because it's, we see people across the range of thyroid cancers. There are lots of people who have early stage thyroid cancers, had surgery, and hopefully will never need to have anything done ever again. And then we have patients who have undergone all of those things, and unfortunately, cancers have come back and they're now on systemic therapy or other options. This is just to remind us that thyroid cancer overall does have a very good prognosis when you look across the board, which is why I suspect some people in this room were told, like, oh, don't worry about it. You got thyroid cancer. That's a good cancer. Like, all the cancers are bad. I don't like any of them. Because there is a fraction of people who end up having cancer recurrences that don't respond to radioactive iodine, and they end up coming to see advanced thyroid cancer providers like myself or Dr. Ryder or whomever. So just as again, a quick reminder, because this does play in to what therapies people end up getting. So we have the differentiated thyroid cancers, and that's mostly what we're going to be talking about today. There are other sessions on medullary for those who are interested. There are other sessions on anaplastic for those who are interested. Those have exciting new therapies, targeted therapies as well. But that's going to be a little bit beyond what we're going to talk about. Most of what we end up seeing in the advanced thyroid clinics are going to be papillary thyroid cancers. Of course, folliculars comprise the second most common. And then what used to be called the Hürthle cells are now being called oncocytic thyroid cancers. That's going to be 5-ish%, depending on where you're looking. So just to remind you, and I have this conversation with my fellows all the time in HEMONC. They say, well, we don't know anything about thyroid cancer. And I was like, that's because the vast majority of thyroid cancer is not taken care of by medical oncologists or endocrinologists who have subspecialty training in advanced thyroid cancers. Because the pattern, as you typically know, is you get surgery, you think about whether you need to get radioactive iodine or not. The endocrinologists are way smarter than me about knowing whether they need to do that. Some people go on TSH suppression, some people don't. You do that for a long time, and then it's usually only after people have recurred a couple of times, or if cancer has grown after radioactive iodine again, or what have you, or that's spread to multiple places, that they come to see either the medical oncologists or advanced endocrine providers. All right. So let's get some definitions out of the way. So when we're talking about radioactive iodine refractory thyroid cancer, what is it that we actually mean? So the definitions were set up a little bit arbitrarily. Many years ago when sorafenib, which I'll actually talk that might be the only time I mention it today, when sorafenib was being developed for thyroid cancer, they had to come up with a way to say, this is who we're including in our study, and this is who we're not including in our study. And so that is, I'd say, where the definitions that we most commonly use came from, was basically from that clinical trial. So if someone, so this is how we define it. So if you know someone has thyroid cancer, so let's say you know they have lung metastases, it's spread to the lungs, you see them on CAT scans, you know it's there. If you do a whole body scan, so an I-123 whole body scan, or you decide to treat them therapeutically with I-131, you do your whole body scan afterwards, that's the WBS, and they have no uptake in the things that you know are cancer, well, you'd say, well, that's refractory, right? Not the radioactive iodine is not going where it's supposed to go. It's refractory. They're on to a different section. If you have uptake in some of the lesions, but not in all of the lesions on the whole body scan, that would be a reason to say if that person has radioactive iodine or refractory thyroid cancer. If there's clear growth within 12 to 16 months of getting the radioactive iodine, how you define clear growth varies a little bit from person to person. Typically, we would use these things called the resist measurements. Have you guys, anyone familiar with resist measurements? All right, we got one person. That's good. You like my fellows. This is great. So when we are looking at clinical trials, or we're thinking about people who might go on to studies, we need to have definitions that we all agree upon. So that if I'm seeing a patient in Aurora, Colorado, and I'm saying something is progressed, that I'm using the same definitions as Dr. Ryder might be using in Rochester, or a provider is using in Paris. We want to make sure that we're all talking about the same thing, because that's the only way you can actually figure out whether you're doing the right thing. So we have these criteria that we call the RECIST criteria. It's RECIST. We're on version 1.1. And basically it defines how we measure things on CAT scans sequentially to decide whether cancers are shrinking, staying the same size, or they're growing. So there are very clear definitions. If you want, you can look them up on the internet. But that's when we're doing clinical trials, or we're thinking about enrolling people in clinical trials. That's often something that we have to do, is these resist measurements to say, okay, how big is something changing, whatnot. So if something has clearly grown, and that usually means that you take a couple of different tumors and you measure them on CAT scan, and usually what's the longest portion of them, and you measure them over time. If something has grown by more than 20% in total, so if one thing stays the same size, something else grows 20%, that probably won't meet the cutoff. But if you have a couple of different things growing, then we call that progressive disease. And you'll hear us use those terms as we're talking about these types of cancers. So most of the time for radioactive iodine refractory thyroid cancer, to make that definition, typically you would say that someone needed to have resist progression 12 to 16 months after getting radioactive iodine. So that's something that we'll use. And you'll hear resist measurements and definitions come up down the road. And then you could also have a lifetime dose of greater than 600 millicuries, which is very uncommon anymore. Back when people used to give a lot more radioactive iodine, that was a bigger issue. So how do we treat these things? So one thing to know is it's okay to wait. We spend a lot of time talking to patients, talking to other healthcare providers, and saying, you know what, like, we're okay. I know that we have cancer there. We know it's radioactive iodine refractory, but truth be told, the odds are still in our favor for a long time. We helped figure this out. There's a consortium called the RIFTOS, R-I-F-T-O-S study that was done over the last, probably 7 years or so. As a consortium of providers across the globe, so not just in the United States, Europe, Asia, et cetera. And we looked at patients who had radioactive iodine refractory progressive thyroid cancer. And basically the big questions that we were looking for was like, when do you need to start systemic therapy? How long can you wait, et cetera? And on average, for the patients who were enrolled in this study, the time from the period of time from when they were diagnosed as having radioactive iodine refractory thyroid cancer, so they met all those criteria, one of those criteria that I just previously mentioned, to the time that they had symptomatic cancer was 55 months. So, almost, 4.5 years, which is kind of, it's probably not as long as anyone would like, but a lot longer than I think the initial concern would be. So that's actually the first time we had some real objective data to say, okay, we can wait for a while. And if so, here's maybe how long we can wait. So it's okay to wait. So, when you hear people, either you hear your provider saying, or you hear other people's providers saying, oh yeah, it's a radioactive iodine refractory, but it's low volume, you're feeling great, let's keep our eyeballs on it. Now we have some data to justify what we've been doing. So we can think about local therapies. So surgery, external beam radiation therapy, radiofrequency ablation, cryoablation. We have all these local therapies that we'll often consider for people who have radioactive iodine refractory disease, particularly something that's growing in just one spot. Yeah. So for radiofrequency ablation. So the question is whether radiofrequency ablation has to be in an area that's accessible. So yes, it does need to be in an area that's accessible, but the definition of accessible varies from the provider to provider. I would say here in the United States, we don't do a lot of radiofrequency ablation of lung tumors, but that is not the case everywhere. In several places in Europe, they'll actually do RFAs to the lungs. You can access, people get lung biopsies all the time, which is the exact same procedure in terms of using a CAT scan, using a needle. The caliber of the needle is a little bit different. And there are some other technical challenges, but you can do RFA anywhere, many places where you can safely get a needle. So we do them in the liver actually all the time. So the question is whether there are limits on the size of targeted areas for local therapies, and the answer is definitely yes. It varies a little bit from technique to technique, but being a non-local therapist, I usually put in my head, if something is 3 centimeters or less, you got a fighting chance in terms of these ablative therapies. If it's bigger than that, usually you start running into troubles in terms of things that are ablative, which doesn't mean we don't do local therapies for palliation or symptom control, but they're just a little bit different. Yep.
One question we have online, are there certain genomic fusions or mutations that are more likely to be RAI resistant?
That's a great question. So the more, so BRAF tend to be more radio resistant. I think this is also true of the other genomic abnormalities that you find here. So yes, basically, as people have driver mutations, the likelihood of radioactive iodine uptake goes down. And then I'll say, Mabel, feel free to unmute now. If there's something that you want to mention, feel free to go ahead. I know you'll get lots of questions on your immunotherapy section in RAI and redifferentiation too. So yeah, local therapies we use all the time. And then I think the other most important thing is making sure people have mutation testing done. You've probably heard this elsewhere, but this is critically important. Not every, in my opinion, not everyone who has thyroid cancer needs to get genetic testing of their cancers done. People who have small, low-risk thyroid cancers, I'm not sure it's worth the expense, et cetera. If you have a recurrence, or someone has a relapse, and certainly if you have metastatic cancer, all those patients should be undergoing either next generation sequencing or at least kind of thyroid specific testing to look for things like BRAF mutation, RET fusions, Entre fusions, et cetera, because it makes a big difference in terms of how we decide to treat people clinically.
For somebody who's had mutation done, let's say in 2014, Sloan's impact testing, it was a big slew of things, right? And already knows, let's say I got 5 or 6 mutations, and then has been on TKI therapy for a very long time, 11 plus years, various therapies. What is the feeling of redoing mutation testing? How likely are the cancers that we're still trying to treat that, even despite all the TKI therapies, has grown, but way less than it would have, let's say, without it? Is there some feeling that to redo the mutation testing 8 or 9 years later?
So people can redo mutation testing. I think like any test, if you do it, you want to go in with the idea of what information am I looking for, and what am I going to do with the information that I get. I think what you don't typically see is, so let's say someone has a BRAF driver mutation, which would be the most common one. Someone's got a BRAF driver mutation, that is exceedingly unlikely that that person, after 10 years of therapy, would have acquired or now have a RET fusion that they could act upon, or an Entre fusion that they could act upon, something that we have a drug against right now. It's not to say you couldn't find potentially a resistance mutations, depending on what kind of panel you're running. You couldn't find a resistance mutation in, let's say, BRAF or Entre or whatever you were looking for. But I think as of right now, we don't have a lot of great data or options in terms of what that next step might look like based upon resistance mutations outside of potentially clinical trials. Because the founder mutation, so that's what we think of as being the main driver mutation. So let's say BRAF or RET, that doesn't change. All right. So if we're saying a lot of people can wait, can watch, eventually many people will need to get treated. So this is a debate that we in the thyroid world have all the time in terms of when we should start therapies. So for people who have symptomatic radioactive iodine progression, I would say that's the no-brainer. So that's, if someone's got cancer in their lungs and they're having more shortness of breath, they're going on oxygen or they're having pain or something like that, that's a reason to say, okay, yeah, it's definitely time for sure. Everyone would agree with that. For people who are having significant growth on CAT scans, I would say many people would start systemic therapies at that time. It's varies a little bit again, provider to provider and institution to institution. But I think if there was, doubling times or people are progressing per RECIST again, within 6 potentially to 12 months, a lot of people would start systemic therapies at that point. And then I said, probably not. If someone has radioactive iodine refractory thyroid cancer, the cancers are small, the person is feeling great. Like I can remember a lady who probably had 100 lung metastases and she went on a bike tour through the Pyrenees. Like I would have made it hard for her to do a bike tour through the Pyrenees if I had put her on LUNAtinib at that time. But she was feeling great, and she was like that for another 2 or 3 years with that same volume. And then, one day she called me, she's like, hey, I have this cough that's not going away anymore. Her CAT scans honestly didn't look that much different, but she was different. She felt different. And I said, okay, here's the time that we have to do something. So here's a little timeline for development. So the first drug that we had approved for advanced thyroid cancer was doxorubicin, which is a real old classic chemotherapy that we still use to treat some other cancers. That was 1974, based upon some changes on chest X-rays for people with thyroid cancer. And then we didn't have any drugs approved specifically for advanced thyroid cancer until 2013. So it was a very long time where we didn't have much. 2013 came along, we had sorafenib, which is a multi-kinase inhibitor approved. And then you see 2015, we had lenvatinib, which was a kind of a next generation multi-kinase inhibitor approved. And then since then, 2018, larotrectinib, also entrectinib, which are NTRK inhibitors, to 2020, selpercatinib and pralsetinib for RET fusions or RET mutations, cabozantinib in 2021, and then in 2022, dabrafenib and trametinib. Even though people were using it pretty extensively before that, it received its blanket approval for not just thyroid cancer, but any cancers that were advanced and had BRAF V600 mutations. So again, for a long time, we didn't have any changes. And now over the last decade, we've had quite a number of drugs come along with a variety of targets. So let's go through those targets a little bit closer. We're going to get a little sciencey, not super sciencey, but you can't give an oncology talk without putting up some graphs and some tumor shrinkage slides. That you'll have to forgive me. All right, so I'm not going to talk about sorafenib because honestly, most people in the US don't use it very much anymore. So we'll start with lenvatinib. So this was the study that led to the FDA approval back in 2015. So it was lenvatinib versus placebo. So half the people, or a third of the people in this study, didn't get active therapy right up front. And those people who had radioactive iodine refractory thyroid cancer. So using some of the same definitions we used. And here's what it showed. So the people on the top were the people who had lenvatinib, and the people on the bottom were the people who had placebo. And this was based on progression-free survival. So the term, when we say progression-free survival or PFS, you'll often hear us say, what PFS is from the time that you start the therapy to when things get worse per RECIST on a CAT scan that we call progression. So that's that time frame. So people are getting CAT scans regularly on these trials or in real life. And basically you're measuring things every single time. And once they get to a growth of 20% or more, or there are new things that pop up, that's when we say, oh, you've progressed. That's when they would define this. So the differences in PFS, so on average, someone who went on to lenvatinib, it took 1.5 years for their cancer to get worse. Whereas the people who were on the placebo enrolled in the study, it took 4 months. So this is why lenvatinib became the standard of care. That's why the vast majority of us use it in the first line, particularly for people who don't have driver mutations. Skipping ahead, so lenvatinib doesn't work for everybody. So they have done studies with other line therapies. So the one that's approved is cabozantinib. Cabozantinib is another multi-kinase inhibitor. It was also tested in people who had cancer progression per RECIST. So your cancer had to be growing before you went on to it. They had to have received a prior multikinase inhibitor. So that could have been sorafenib or lenvatinib, or they could have gotten both. And interesting, this study excluded people who had been on BRAF inhibitors, which is an important thing to know. So just in terms of keeping track of things. So the pictures are a little bit smaller, but the ideas are the same in terms of PFS is on the top, and then overall survival is just whether people are still around or not. But that top number is the one to focus on. And just like you did with the other study, you saw the people on that top curve. Those are the people who went on to Cabo. The people on the bottom curve were people on placebo. So on average, people did a heck of a lot better who went on to the Cabo in that study as opposed to the people who were on placebo. And then this figure that you see on the other side, we call that a forest plot. And basically what that means is, when we're looking at what studies, we're wondering, okay, how do things look for everybody who went into it? But then we always have questions about what we call subgroups. So how did it differ for men versus women? Did it differ whether someone had follicular thyroid cancer or papillary thyroid cancer, et cetera, et cetera? And so these studies can help us figure that out, or these figures can help display that. So the forest plot here, because everything is to the left, tells us that all the patients, every subgroup we looked at, the Cabo worked better than placebo did. So that's why oftentimes that's our second line option, particularly for non-driver mutations. So those are the kind of multikinase inhibitors. The nice thing about the multikinase inhibitors is they should work regardless of mutation profile. The downside is the side effects are a little bit rougher on average. So a lot of them cause high blood pressure. They cause diarrhea. They can cause fatigue, decreased appetite. They can be a challenge to take care of. Yep. So pneumonia. So the question is about pneumonia as a side effect for Lenvima. So certainly we don't think of the multikinase inhibitors as being classic, immune suppressive drugs like cytotoxic chemotherapy might be, but certainly they do alter people's immune systems and general tolerance for things. And the other piece of things is many people who go on to thyroid who are being treated for these have lung metastases. So certainly pneumonias are not uncommon. I don't know, and maybe Dr. Ryder does, I can't think of associations between the multikinase inhibitors and unusual pneumonias, which is not to say it doesn't happen, because these things will happen. Yeah. Aspergillus is definitely, is a terrible infection. I'm sorry you had to deal with that. I've certainly never seen Aspergillus or other fungal infections on multikinase inhibitors. Yeah. But, fungal infections, Aspergillus is a fungal infection. And Aspergillus loves to set up in lungs where you have pre-existing cavities. And certainly people who have thyroid cancer, many of them have pre-existing cavities in their lungs. So I wonder if that was the setup. So I say, fortunately, we have lots of targeted therapies now, not just the non-selected multikinase inhibitors. So there are two out there for for people who have RET fusions, mostly for differentiated thyroid cancers. We're talking about fusions. So, not mutations, but fusions where it combined with some kind of combined with another gene. So the two out there are selpercatinib and pralsetinib. So overall response rates, you'll hear me talk about this, going back to that RECIST idea, these are people whose cancers have shrunk by 30% or more. That's how we define a response. So with selpercatinib, RET fusions, it's 79-ish, depending on what study you look at, it's going to be that 70, 80% range. AEs, those are adverse events. So those are side effects. The main side effects, high blood pressure, liver function abnormalities. We have to check people's liver functions every 2 weeks for the first 3 months when they're on this drug. Low sodium levels, diarrhea. And this medication is twice a day. You take it with or without food. Pralsetinib, similar response rates, similar side effects, probably not quite as much in the way of sodium issues, but probably a little bit more in the way of GI issues. It's once a day, it's fasting. So again, when we're looking at these studies, this is from the selpercatinib study that was not specific to thyroid cancer, but they broke out the thyroid cancer groups. Here this is what we call a waterfall plot, which is basically how you look at each bar as an individual patient. And then the bar going up or down is whether their cancer shrunk, grew, or stayed the same size. So here we see this 30%, or there's this dashed line across. at minus 30%. That's that 30% shrinkage rate that I was mentioning, which is a response per RECIST. And you can see each individual patient, they're describing whether it's papillary, poorly differentiated anaplastic, Hürthle cell, or oncocytic. And you can see the vast majority of people's cancers shrunk substantially who went on to selpercatinib who had a RET fusion. This is why this drug got approved. This is why we use it all the time. These are some patient images I borrowed from Dr. Ryder. Much thanks to her for providing these particular images. So this is a patient of hers who went on to one of the RET inhibitors. You can see at baseline, a patient had some tumors in those gray blobs on the right side of the lung, I'm sorry, on the left lung on the top. And then just a month later, all those tumors had shrunk substantially. So you can see big improvements in people's tumors and tumor burden and tumor-related symptoms on these RET inhibitors. And as following in the same vein, we have Entre. Entre is another kinase. It's also a fusion, typically, not a mutation. And it is much less common. It's less than 5% of recurrent papillary thyroid, less than 5% of recurrent differentiated thyroid cancers. Interestingly, it's a little bit more common in people who develop thyroid cancer at a younger age. So if you develop thyroid cancer in your 60s, 70s, 80s, you are less likely to have some of these fusion events than if you were in your teens or 20s. So the two drugs that are approved, so there's larotrectinib, also a high response rate, at 70 to 80% range. Side effects, also liver function abnormalities, fatigue. It can cause MSKL or musculoskeletal symptoms and causes like achiness. And then it can cause some weird neurologic problems. They're usually transient. So the N in NTRK or NTRK is neuro. So this is the NTRK is expressed in a lot of neurons or nerve cells. So oftentimes when people start these NTRK inhibitors, it's very typical to get irritation around we call it periorbital or perioral sensitivity. So people get like numbness or tingling around their lips and their mouths. These medications can cause problems with our cerebellum. So the cerebellum is the part of our brain that controls balance among some other things. So a lot of patients have told me when they start these medications, they feel almost like they're drunk. Not from like a cognitive thinking standpoint, but from a woozy instability standpoint. It gets better over time for most people, but it is kind of typical across that whole spectrum of drugs. So larotrectinib and then entrectinib has a response rate in that 50 to 60% range, so maybe not quite as potent. It has some other side effects. It has the same things as larotrectinib does, because they're kind of class effects, but it also is maybe a little bit more likely to cause cardiac problems and to cause blood problems. So it's also daily. It's once with or without food. So this is a patient of mine who had an NTRK fusion, and we put on one of the NTRK inhibitors. You can see on the left side, that's her lungs, all those little white dots. Those are areas where her tumor had spread. And then the scans on the other side, that's what her CAT scans looked like after 2 months. So she was not terribly symptomatic when we started her, but she had a large volume of cancers. So and she had an activating mutation. So that's why we decided to start her on systemic therapy. And her scans basically look the same now 2 years later. Similar type of story, this is waterfall plots. So waterfall plot looking at all the patients. This is with selpercatinib. I'm sorry, with larotrectinib. These are all the thyroid patients on larotrectinib. You can see the vast majority of people had significant shrinkage in their cancers who went onto this drug. And then last but not least, BRAF and MEK inhibition. So BRAF mutations are the most common driver mutation in thyroid cancers. I put it last because this is technically the most recently approved for us. Here, this is a study that several people did looking at dabrafenib, which is BRAF specific, or dabrafenib plus trametinib, which is a MEK inhibitor that we often use in conjunction with dabrafenib. Same type of story you see on the waterfall plot there. The majority of patients who go onto these drugs have significant shrinkage in their cancers. It's about 50 to 60% of people who meet that RECIST criteria for responses. And so this drug is now approved for people who have BRAF V600E mutations. So this is doesn't come across great, but it's a kind of an algorithm that is proposed by some people for how we take care of these cancers. So for people who have radioactive iodine refractory thyroid cancer and require a systemic therapy, typically I think what we'll do is we'll look to see if they have an activating mutation or not. If they have an activating mutation or not, and they need systemic therapy, I would say the vast majority of the time, certainly if they have an Entre or a RET fusion, that's the type of drug that we'll put them on. It's a little bit more debatable, I would say, whether you would start someone who has a BRAF mutation on a BRAF combination therapy, or you'd put them on a multi-kinase inhibitor. I think if you poll 100 thyroid cancer doctors, you will get 50 people saying one thing and 50 people saying something else. So that's normal because we're all humans and we all have our own opinions. But you'll find different people do different things in that particular setting. But if someone has a BRAF mutation, at some point they're going to get the BRAF MEK combinations. So what's new? So in terms of targeted therapies, so there are some new RET, kind of next generation RET inhibitors coming down the pipeline. So those would hopefully maybe bind a little bit more tightly to RET. So they might be effective in people who had already been on one of the RET inhibitors and the cancer was growing. These are not necessarily in people yet. These are still, some of these are still preclinical and just being tested in test tubes in rats. Entre inhibition, so there's a drug called Pemetrexed, which is kind of a next generation RET inhibitor. I'm sorry, next generation Entre inhibitor that is in clinical trials and is out there. And then there are next generation BRAF inhibitors. So things that are binding in a slightly different area in BRAF, which I think are pretty exciting, but they're all very early in development. And that is kind of the main piece in terms of the targeted therapies. So I'm going to turn it over to Dr. Ryder, and then she will talk about, I think, some exciting ideas in terms of immunotherapies for thyroid cancer and redifferentiation therapy, which is a hot and controversial topic.
Thanks, Dan. I'm going to try and share my screen.
Yeah, so I'll see if I can.
Hold on one sec. I think we have a question.
Excuse me, just before we move on, I have a real quick question. So on the PFS on the Lenvima, that's from the original study was shown to be about 18.3 months.
Yep.
Has that improved over time?
No, that's been pretty, the good question. I'd say it's fairly consistent. I mean, we've never, one of the things that's always troublesome is when you're looking at clinical trials, the clinical trial data and real life data never are exactly the same, in part because the people who go into clinical trials usually have to be the healthiest of the patients with this problem because you have to qualify for it. And if you're traveling for it, you have to be healthy enough to travel and have the resources to travel for it. So there are confounders that make it more problematic. But I think on average, when you look, it's around that same, it's around that year and a half. But again, that's an average. I think my personal record on Lenvima was 7 years, which is a lot longer. And he was actually on that original registration study. So that's, one end of the spectrum, but there are unfortunately other folks, who go on and 4 months later, the medicine wasn't doing its job and we have to come up with another plan.
Good morning, everyone. I'm sorry I'm not able to be there in person, but I really appreciate the ability to present virtually. I'm going to try and talk a little bit quickly because I do want to leave time for questions. Okay, so Daniel did a really nice job of going over what's available for advanced thyroid cancers. I'm going to talk a little bit about off-label treatments, and this is the lens through which I see my patients in both my endocrine and my endocrine oncology patients. And it's really a spectrum of patients with differentiated thyroid cancer, with patients on the left, very asymptomatic, very low tumor burden, to patients in the middle with moderate tumor volume, but generally asymptomatic, and then patients on the right with the most advanced disease. So when I see the patient primarily in the middle here, the patient who has macronodular lung disease, but is not symptomatic, and I think they're in time, as Dr. Bowles showed, in maybe about 5 years or more, may progress to more larger volume symptomatic disease. I start thinking about what therapies I might be able to offer maybe now that might delay the progression to more advanced disease. And so in this context, we're going to talk about radioiodine redifferentiation. We'll talk also about some cytotoxic chemotherapy that I snuck in. Hopefully Dan's okay with this. And then some immune therapy on on the horizon. So an example for this type of moderate disease volume is this patient of mine, 64-year-old male with papillary thyroid cancer. He's got lung and bone metastases and received a couple doses of radioactive iodine. And his tumors remain small and very slowly growing, but his TG is rising. As Dr. Bowles recommended, we do Tempus next-gen sequencing. We use Tempus, and he has a RAS mutation, not directly targetable. His thyroid tumor marker is about 400s, and on his previous RAI scan, he did have some iodine uptake. And this patient is a maximalist. He wants to do everything we can to try and control and shrink his disease. So in this context, we think about radioiodine redifferentiation. And the science behind this was proven and shown by Jim Fagan, my former mentor at Memorial Sloan Kettering Cancer Center. And what Jim has showed in the lab is that the mutations that drive thyroid cancer also inhibit or impair the iodine channel. They cause loss of expression of this iodine channel. And if you can't express the iodine channel, you can't take up radioactive iodine. I'm sorry, my pointer is not working, so I don't think I can point. This inhibition in iodine's uptake and iodine incorporation is reversible. If you target the driver mutations, for example, with BRAF mutation, perhaps with a RET fusion, or downstream of the BRAF, RAS, or RET mutations called MEK inhibitors, you might restore iodine uptake and allow greater benefit from radioiodine therapy. So this is the science behind what we call radioiodine redifferentiation. And when I think about redifferentiation, I'm wondering, in the asymptomatic low volume patient, can I cure them with a dose of iodine? For the moderate volume patients, can I prevent them from going to more advanced symptomatic disease? And for the patients with advanced disease, can I salvage their disease and move them to the left with disease, but less tumor burden and less symptoms? And so for the patient that I presented, we're really talking about delaying the need for TKIs or MKIs. So in other words, a sort of preventative measure. And so in this patient who wants everything done, we have a discussion about the uncertainty about redifferentiation, and he elected to proceed with this off-label treatment. He received trametinib for 1 month. And then we repeated his iodine whole body scan, which you can hopefully see here well, with much greater uptake within his lung nodules shown on the left, and then the SPECT CT in the middle. All those red hot spots are areas of iodine incorporation, which is much more intense and diffuse than was previously without the trametinib or the MEK inhibitor. And so we have just submitted our manuscript on our Mayo Clinic series of patients with redifferentiation. And this complicated figure is called an oncoplot, where basically all the patients are across the top, and then across the left and down are just different parameters that we look at to see who are the responders to redifferentiation and who are not. And so of about 31 to 33 patients on the left are those that responded to redifferentiation, which means they received a drug, either a MEK inhibitor or BRAF inhibitors, trametinib and dabrafenib, and then had repeat iodine whole body scans. The ones in green at the top are ones that redifferentiated, meaning their cancers took up iodine, and they went on to receive I-131 therapy. And then the gray bars on the top are the ones who didn't redifferentiate. They only received drug for a month and then did not receive further radioiodine therapy because their iodine scans remained negative. When we look at the summary of this really large kind of lots of parameters, what we found is that the patients with follicular thyroid cancers, follicular variant, were more likely to redifferentiate and receive a benefit from I-131. Patients with high thyroglobulin levels of at least 100 or more. All patients with RAS mutations, and only about 30% with BRAF mutations redifferentiated. And again, this bar shows the RAS, which are the brown boxes. All of the RAS tumors redifferentiated and received I-131. Whereas only about a few, 30% of the BRAF mutants responded. Importantly, when we look at redifferentiation, we looked at not only those that redifferentiated on the left green bars, we also looked at the outcomes of those patients who received drug for only 1 month. And what we found is that the RECIST responses were the same in both groups. So although the patients who redifferentiated and received I-131 therapy had responses, they were basically similar RECIST responses to the patients on the right who didn't get I-131. So there was a drug effect of just 1 month that helped shrink the patient's tumors. The I-131 patients did have greater, on average, tumor shrinkage than those who didn't receive I-131. But when we looked at overall progression-free survival, it was actually the same. So not sure the benefit of redifferentiation. Importantly, when we looked at outcomes of survival, there were 5 patients who unfortunately died of their disease, suggesting that this is really an advanced patient cohort that we were studying. And those 5 deaths all occurred in those who had undergone redifferentiation and I-131 therapy. And importantly, there were 2 cases of anaplastic transformation. 2 patients developed, again, what we call an undifferentiated, highly aggressive form of thyroid cancer called anaplastic thyroid cancer. 1 case was probably expected based on the biology of her disease, but a 2nd case was completely unexpected. And so we don't know in patients with advanced disease whether redifferentiation may be selecting for more advanced disease or inducing mutations that might tip patients to more advanced disease 1 and 2 years later. So as I think about redifferentiation, this kind of simplistic cartoon, the patients with follicular type of phenotypes are the best. Those with RAS mutations and high TGs earlier in their course might be more effective. Whereas BRAF-driven disease, those with low thyroglobulin levels, and BRAF with other mutations such as TERT and ARID may not be good candidates for redifferentiation. So what about other salvage treatments for patients with advanced disease? Dr. Bowles talked about immune therapies. And so I want to highlight what's on the horizon and coming forward for differentiated thyroid cancer. And this is called CAR-T immune therapies. What CAR-T therapies are, CAR stands for chimeric antigen receptor here in the middle. So what this is you take a patient's T cells. These are the cells that fight cancer. You have them engineered to express a receptor to your cancer. You then give these T cells back to the patient, and we hope that these yellow antigen receptors then go and activate the T cell when they find the tumor. And it sort of looks like this in a cartoon. Hopefully you can see my pointer now. This is the CAR-T, this is the T cell, this is the engineered receptor, and right here is the specificity of this receptor to the target, the tumor cell, and this is the target. When this CAR-T binds to the receptor on the tumor cell, it activates a killing signal within that T cell. That T cell then releases granules and particles that cause tumor cell death and cytotoxicity. And the way it looks like CAR-T therapies is you take a patient's, this is autologous, you take a patient's T cells by a blood draw, you harvest specifically their T cells. You then take those T cells to the lab and you engineer a gene so that they can express the receptor that's specific to that cancer. You grow those T cells in to the millions. You give the T cells back to the patient and you say, T cells now go and fight the cancer and kill the cancer. So on the horizon are 2 CAR-T therapies that are being developed. One is a TSH receptor CAR-T developed by the Copeland and Kinderian lab here at Mayo Clinic. And we're hoping that within a year or so, we'll be able to move this forward to a clinical trial. There's a TSH receptor CAR-T that was developed in China, and there's preclinical data published on that. And in a similar type of approach, but slightly different, the Fagan lab at MSKCC has a TSH receptor CD3 bite-specific antibody. So these are antibodies that express the TSH receptor on immune cells, and hopefully by binding to differentiated thyroid cancers that express the TSH receptor can induce cell death. And based on redifferentiation and what we know to be true of the different histologies, there will probably be a genotype-phenotype prediction of who are the best responders to this type of approach and which tumor types in differentiated may not respond well. Fortunately, just like redifferentiation, it may be possible that papillaries driven by BRAF and other mutations that may not express the receptor well might be able to re-express it with BRAF or MEK inhibitors. And then finally, just in the interest of time, I wanted to sneak in not necessarily a novel treatment in the field with a novel chemotherapy, but with an old chemotherapy that we have found success in. And this is Pemetrexed carboplatin in advanced thyroid cancers. So Pemetrexed is an antifolate, and it's approved for different types of lung cancers. And folates are involved in the synthesis of DNA and RNA. And so if you can block this folate pathway, you can prevent cells from replicating or dividing because they lack the tools for their DNA and RNA replication. And very early on in 2009, there was a phase 1b study with Pemetrexed and a separate drug listed there, a PKC inhibitor. And what they found in this phase one study were that all of the responders were actually thyroid cancer patients. There were 3 objective partial responses, and then 20 patients had their best response as stable disease. And for a phase 1 study, that's actually pretty impressive. So we are also publishing our case series on this approach. We have a table here of about 9 patients, 5 of which had responses, partial responses to Pemetrexed and carboplatin. This is again a cytotoxic chemotherapy. And we'll be publishing this data hopefully soon. This is a patient who wrote back to us. Dr. Bible was my mentor at Mayo, who showed me this treatment. And this patient really wrote back saying, this treatment is amazing. This is an example of a patient who had a tumor eroding through his mandible, and over the course of 3 years had a near complete response, and this treatment was durable. This is an adrenal metastasis on the left that really responded well. This is another patient with papillary thyroid cancer who had progressed on 3 or more previous chemotherapies, and then on Pemetrexed alone, which she remains on today, over 3 years later, continues to respond. And we have one anaplastic patient as well, who had progressed on multiple lines of previous treatment and remains on Pemetrexed carbo with an impressive response. So we're excited about this chemotherapy. Unfortunately, we cannot get pharma support for it. So we're trying to think of ways, once we publish this case series, to try and open a trial and using this as perhaps insurance build and try and see what our outcomes are on a larger scale. So I think the time now for seeing, the time for patients with advanced thyroid cancer differentiated is quite improved. And we definitely have an individualized approach and lots of tools in the toolbox. Oops, I just want to give a last plug to ITOG, the International Thyroid Oncology Group. I promised Dwight Vicks that we would show the ITOG slide. ITOG is a society nonprofit organization led by thyroid cancer teams across the country and internationally to try and find a cure for thyroid cancer through clinical trials. And this was our meeting recently in Naples, where the theme, I'm a secretary of ITOG, and our theme was clinical trials. And so we had a lot of discussions about future trials for patients with thyroid cancer. So thank you. I hope that wasn't too fast.
Dr. Ryder, that was great. I saw one of the comments that came up in the chat was about what do we know about side effects from CAR T therapies?
Yeah, so CAR T therapies are incredibly potential for toxicities from cytokine release syndrome and can even be life-threatening. The benefit of use of an endocrine gland developing a CAR T is that the TSH receptor is very specific to thyroid tissues. And so there should be very predicted, very low off tumor on target side effects. And so far in preclinical studies with the TSH receptor, at least in mouse models, the toxicities have been very negligible. And we would predict in humans potentially as well. But that's why we need the clinical trial.
I'd say CAR Ts are, as the medical oncologist, CAR Ts are approved for a number of different blood cancers at this point. There are CAR Ts for ALL, multiple myeloma, some forms of lymphoma. When they work, they can work great. It's been hard to develop them for solid tumors, in part because solid tumors are actually a little bit more complicated than blood tumors. But then, like Dr. Ryder was saying, finding the right target is a bigger challenge in solid tumors than it is in blood cancers. The other thing about them is they are terrifically expensive. The average cost for a CAR T is somewhere in the $500,000 to $1 million range when you include the whole process. So you can imagine doing it for all patients who have radioactive iodine refractory thyroid cancer would not be tenable unless none of us wanted to eat ever again. So, yes, we got lots of questions.
So I'm curious about how important a role thyroid globulin plays in the redifferentiation process. I'm a RET fusion fully differentiated, RET turned 7 other mutations, but I don't make thyroid globulin. I've talked about the redifferentiation process down the road once my RET inhibitors stop working, but I'm curious about the thyroid globulin.
So Dr. Ryder, I think this question will be for you. The question is, I think for patients who are interested in redifferentiation therapy, how important is the thyroid globulin level in determining likelihood of effectiveness? Is that all right? I think that's the question for you.
Yeah, I think the thyroid globulin really is reflecting the biology of the particular thyroid cancer. So follicular thyroid cancers, follicular variants, and RAS-driven thyroid cancers, those are much more thyroid-like. They express NIS, they continue to express NIS, and they have high thyroid globulin levels. So I think it's the constellation of follicular variants, RAS-driven tumors, those all go along with high TG producers. The BRAF-driven tumors tend to not have great thyroid globulin secretion for their proportional disease. But if I do find a BRAF mutant tumor that's papillary and that has a really high TG, I am more likely to think about redifferentiation. If they're BRAF mutants and they have very low TG levels for their tumor burden, I'm really unlikely to put them through redifferentiation based on our data series.
Would you say that the more thyroidy the cancer looks, the more like, at the get-go, the more likely it is to respond to redifferentiation therapy?
Right. So in the data that I showed, those that are more thyroid-like are the follicular thyroid cancers, the follicular variants, and the RAS-driven tumors. And that's probably because the MAP kinase pathway is turned on, but not as strong as with BRAF-driven tumors. BRAF-driven tumors, which are the papillaries, the majority are BRAF mutant. The MAP kinase pathway is probably, as what Jim Fagan might say, it's very heavily turned on. And they probably have some other alterations, often TERT, and other things that are probably impairing their thyroid likeness.
With somebody who already has an autoimmune disease, say like ulcerative colitis or something else, they automatically exclude from the CAR T discussing along those lines, but they basically.
Yeah, so I'll answer this question. So the question is basically, if someone has a pre-existing autoimmune condition like ulcerative colitis or rheumatoid arthritis or whatnot, even if it's under good control, how does that go into our decision-making for immune therapies? So for thyroid cancer specifically, we don't know because the immune therapies are not used extensively at present for thyroid cancers, with the exception of maybe poorly differentiated and anaplastic cancers. Knowing for other cancers where we're using immune therapies all the time, we know that the risks of making those immunotherapies or making the risks of making those immune diseases worse is substantial. So for people who have had organ transplants, let's say, so if someone had a liver transplant, they're on chronic immune suppression to keep their transplanted liver working. Those patients are not great candidates for immune therapies. So, and I think particularly in the clinical trial setting, you know, and for better or for worse, when we're in the clinical trial setting, you try to pick the cleanest patient population. So I think that would be a real challenge in the study until you had extensive safety data. So I think that my guess is that, not having seen all the protocols for CAR-Ts for thyroid cancer, I suspect in autoimmune conditions, with the exception of something like Graves, would probably be exclusions.
We have one online question. Is everyone with BRAF mutation RAI refractory, or what percentage does RAI treatment work for? I have BRAF, wondering what chance it will work.
Doctor, so I don't prescribe the radioactive iodine. I have much smarter endocrinologists who do it for me. So I'm going to ask a smarter endocrinologist, Dr. Ryder. What do you think?
Yeah, I think partly we don't know the full answer to this question, but as we do more and more studies, the number of patients that radioactive iodine truly cures is very low, exceedingly low. If you're a high-risk patient, meaning you have large tumors, locally invasive, more than 10 lymph nodes, extension to important structures, we do tend to give radioactive iodine. That's what the guidelines suggest. But unfortunately, the patients with the most advanced disease are the ones that are less likely to respond to standard of care radioactive iodine. And when we push that system with redifferentiation to try and force them to express the iodine channel, it still works in only a small group of BRAF mutant advanced papillary thyroid cancers. So the answer is we've never, and the truth is there has never been a clinical trial looking at the efficacy of radioactive iodine for patients with distant disease. It's always been standard of care, and it's been done as historically because that's what we've had and that's all we've had. But the reality is Laura Bucay published on exceptional responders to radioiodine therapy, and she looked long and hard for those patients. And there are some, but they're by and large a minority of patients overall.
We are at time.
Thank you, everyone.
Thank you, Dr. Ryder.
Thank you. Thank you, everyone. And thank you to ThyCa for this conference.